I'm Orhun Kantarci. I'm a consultant in the Department of Neurology at the Mayo Clinic. Multiple sclerosis is a disease that affects what we call the central nervous system. It does not affect the peripheral nerves. It is a disease where the myelin, which is similar to basically plastic around cables, is damaged by your own immune system. And that immune attack leads to lesions that are marks, what we can see with an MRI. And that's what's responsible for the symptoms of the disease. We know today that these are what we call relapses, which are associated with these individual immune attacks to the nervous system. In the past, we also knew that was the case, but we also know today that sometimes you don't get at all symptoms due to these attacks, and you can have lesions form without any symptoms and go away. In some cases, most of the cases, they leave a mark in there. Usually for most patients, when they get these attacks or relapses, we call it, they will recognize it as something that's coming on over the course of hours to days. It's not as fast as, for example, like a stroke. It doesn't hit them hard. It comes in rather over the course of hours to days, peaks for a while, and over the course of weeks to sometimes months, it recovers to a certain extent in some people, fully in some others. And that's what they will recognize, this waxing and waning symptoms. If it affected the brain stem and the balance centers, your balance would be affected. It depends randomly on where these hits happen in the nervous system. There is an autoimmune component to this. The question is, how well have we proven it, and how much of MS is really autoimmune, and how well can we model that? There are several models of multiple sclerosis, and one of them is an autoimmune animal model. That doesn't mean MS is autoimmune, just the model is autoimmune. There's several things about MS that don't fit the autoimmune hypothesis, as we call it. On the other hand, there are several things, such as the association with what we call the HLA genotype is fitting with autoimmune hypothesis. So it's still a debate, but most of our treatments that we've generated from autoimmune models of MS have worked at different extents in patients. So one can make the argument it's clearly immune mediated at some stages before progression, like in the relapsing stage. Whether the initiation or propagation of the disease is still autoimmune, was it just the initiation or just the propagation, or both? Those are the things we don't really know still as well as we would like to. There are a couple of things we know. For example, we know that because of the genetics being more prone to Caucasians and women, we know, for example, sunlight and vitamin D has an impact in initiation of disease. At least there's an association with lack of vitamin D, lack of exposure to UV light, and increased risk of multiple sclerosis. There is an association with Epstein-Barr virus, basically having had infectious mononucleosis and increased risk of MS. Doesn't mean it caused it, whether it just provoked a cascade of events that led one to be more prone to disease, we don't know, but at least we know there's an association. There's some controversial evidence, but clearly suggestion that smoking increases risk of multiple sclerosis. And obviously that's not the only reason to tell somebody not to smoke, but it's a good reason to also support the idea that neurological diseases can worsen and be caused by smoking. And the other piece of evidence that has come up recently over the last few years through the studies is obesity and weight is associated with increased risk of MS. How that works, we don't know. We know hormonal changes do affect MS because during pregnancy, patients do rather well. They don't have enough relapses during that time, which is good. But then post-pregnancy, things catch up. So we know a lot about pieces of the etiology, but it's hard to put it together as a pinpoint cause yet today. There's two types of treatment for MS, obviously. One is to manage symptoms. To give an example, if somebody has a headache, we give them a headache medication. So MS patients can have difficulty with urinary tract infections, you treat the infections. They may have difficulty with what we call spasticity, that is stiffness in the legs or arms, we can treat that. Those are symptomatic treatments. The disease-modifying medication we're talking about that came from autoimmune models of multiple sclerosis are really not symptomatic. What they are is they do change the course of the disease to an extent, meaning they prevent new relapse from happening. Therefore, it's not really a symptomatic treatment. All these very expensive treatments, really that's what they do. They try to prevent new relapses from happening. And we know they work. The question is amounts and individual variations, but they do work in a population level. A lot of things we can do in life will help multiple sclerosis at different levels. First of all, I give the simplest example. If you're overweight and if you're not exercising and you were unlucky to get a bad multiple sclerosis relapse, let's say affects spinal cord and you get paralyzed, the recovery period will be way more prolonged than the person who's fit. Just starting with that simple analogy, yes, being fit, exercising regularly, losing weight, just living a healthy life, you don't have to be a competitive athlete, is going to make a big difference, just for that simple fact alone. Overall, though, there's been many other benefits. For example, fatigue is a very big problem in multiple sclerosis patients. Fatigue due to multiple sclerosis is a problem. But when we talk to our patients, a lot of the time we recognize most of their fatigue is similar to yours or mine. They don't sleep, they have kids, they have lives that they have to live, they have deadlines, they have to work very hard. So rest, sleeping well, losing weight, and exercising are the number one things we can do. And I said number one things because they work together as a unit to fight fatigue in MS. Most of us don't emphasize this enough as physicians, and I think we need to pay more attention to it on our side. So there's a big deal. All the treatments we have today are to prevent relapses. We still haven't tackled the idea of once the neurons start degenerating, breaking down, which is the bigger part of the disability, which is the progression as we talked about. How do we repair that? How do we get those neurons back to normal shape? Or how do we in the first place prevent them from breaking down like that? Everything else we've done, despite the fact there's been millions of dollars, trillions of dollars invested into MS research, it's always been for the low-hanging fruit, basically to treat the relapses. But the bigger disability comes from the progression, and we still haven't tackled it. So that's the area, that's the direction that we would like, as MS researchers and physicians, as the MS Society has pushed forward as well, as the NIH grants have been supportive of, to see that the MS research goes to. That's the direction that we'd like to see. The key message is that MS is a bell curve. There are people who do really bad, but there are a lot of people who do extremely well, and there are people in between. Indeed, if you look at the patient numbers, the patients who end up having really bad disease course early on, let's say take the first 5 years and take example of a patient with too many recurrent relapses that we couldn't prevent, that left them with big damage, they can't repair very well, and if they end up in a wheelchair in the first 5 years. That would be an absolutely disastrous scenario for a patient. If you take the number of those patients, or percentage of patients that go through that direction, and look at the percentage of patients 25 years down the road, you wouldn't even know that they had MS. They're about the same. So first is to have this even-keeled understanding of the disease for the patient. Because if they don't, there's a very pessimistic approach to disease, and if they find out, okay, 1 in 5 do really bad, but 1 in 5 do extremely well as well, and there are a few things we can use to determine that early on, it's good to get them a good plan in life. And the rest of the patients fall in between, the 3 and 5, and most of them will do well. The average person that's 50% of patients, may need a cane to walk in about 15 years, but the other 50% doesn't. So, and that's good news. There are good prognostic factors, what we call, that determine a rather benign course in the disease. It's called benign MS. We don't want to imply that MS is a benign disease, but there's a subgroup that is relatively benign. That's why it's called benign MS. Some of these things are early age at onset, female gender, the fact that the patient recovers very well from the early attacks. There aren't too many early attacks. The MRI doesn't show much activity early on. When they get onto treatments, the treatments work well for them in terms of prevention of new relapses, new MRI activity. Those patients generally do well. So once we understand this concept, I think for patients, it's a matter of time and follow up with the physician, a tight connection with the physician, and seeing how things go before we can really say which direction the disease is going to take. And it will be always nice to get an early handle on it. So if we need to prevent relapses, we can do aggressive treatments early on if needed. But if you are doing well, not to rush into aggressive treatments and take time. And some patients, if they're doing great, we don't even treat them early on. We just watch them. All of this is what I tell a patient.